Okay. Welcome, viewers, to our ongoing program Focus, coming to you here from the Channel 17 Center for Media and Democracy in Burlington, Vermont. I'm your host, Margaret Harrington, and viewers, let's welcome our special guest, Ed Baker, Vermont Substance Abuse Counselor. Welcome to Channel 17, Ed. I'm so glad you came.
Thank you, Margaret. I'm very pleased to be here.
Yes, and our subject, the title of our program is the opiate abuse facts with you, Ed. And so, Ed, from the top, you are a clinical social worker and a licensed addiction counselor here in Vermont. Can you give us some idea of the extent of this crisis, of the opioid crisis? We need a waking up.
Yes, I can. And as before the program we were chatting a little bit, I kind of mentioned that we need a waking up, but we need to wake up on the right side of the bed. We need to be informed about what is going on. We need to have compassion, passion in our hearts for this particular group, this particular population, people with substance use disorder. But we also need to be based in science. We need to understand the medical science, some of the breakthroughs that have occurred over the past 40 years, actually, when it comes to identifying and defining addiction as a disease of the brain. I just want to say before we begin that I'm very pleased to be here. I have, my life has been dedicated to this. I've been in the field for 33 years. I'm in a personal recovery myself from addiction. I'm a licensed independent clinical social worker and a licensed alcohol counselor. I've dealt with this specific population for 3 decades in an office doing therapy with them. And I'm here really to convey what it is that causes people to develop addiction, how we can best understand them, how we can best help them, and what we can do on a daily basis to really spread compassion within our community.
Well, we're here in 2017, and Ed, we met at the Mayor's Book Club with a discussion of this book called Dreamland by Sam Quinones. Mm-hmm. And this was a very, very good discussion, and you spoke there, and you riveted my attention, Ed. And so what is the extent of this epidemic?
Well, thank you for asking, because it's certainly one of the most important questions that we have today in our culture. I thought we would jump right into it. And these 2 numbers are staggering. They are reason for alarm. In 2014, almost 29,000 people died of opioid overdose. These are deaths in our country, 29,000, almost 29,000 in 1 year. In 2015, that number increased to 33,000 deaths. 33,000 people who didn't want to die died of opioid overdose. This is 33,000 families devastated by this particular disease. This is how it happened, and this was a lot of what Dr. Quinones was talking about at his presentation. If you take a look at this slide, it traces through our history the development really of what I call 3 streams of tragedy that have fed into what has become a whitewater of fatality in our country. In the middle of the slide, you'll see that purple line. That represents pharmaceutical opioids. So hydrocodone, oxycodone, OxyContin, morphine, codeine, the types of drugs that you hear about every day that are stocked in our pharmacies routinely. If you notice, there's a steady increase in that particular line from 2000 right over to 2015. This is pharmaceutical opioids. Our country was flooded with pharmaceutical opioids. They were overprescribed. People were not instructed on safe ways to use them. The medical profession and the pharmaceutical companies all seemed to believe that there was a very low potential for addiction when it came to pharmaceutical opioids. So they were prescribed for chronic pain, and the result has been disastrous. So that's one population of people with opioid addiction in our country. If you look down one line to that blue line with the severe increase between 2012 and 2015, that represents heroin. That was what Sam Quinones was talking about. There's been an influx of heroin. We've gotten a little bit of a grip on pharmaceutical opioids as far as the rate of growth of fatalities. But what's happening is what's called international crime organizations they see a profit margin. So they're coming into our country with other opioids. They're underselling illicit pharmaceutical opioids. They're selling very pure products, and they're reaping rewards, financial rewards. So you see between 2012 and 2015 about a tripling in the rate of death specifically attributable to heroin. More alarming, shocking actually, is the orange line across the graph. That's what's known as synthetic opioids. You'll hear about them today on the news and in the newspapers, mostly fentanyls. They're called IMFs, illicitly manufactured fentanyls. These are the most potent opioids known to the pharmaceutical industry. These are produced in China, shipped over to Mexico or Canada, and then they find their way into the United States. So you have heroin from Mexico, illicit fentanyls from China, and pharmaceutical opioids. Basically, there are three sources of fatalities in our country today. If you take a close look at this grid, this breaks my heart. This is Vermont. This is Vermont between 2010 and 2016. So 41 deaths attributable to opioids in 2010, 106 in 2016. So you see the progression. 2017, we're expecting the same trend to continue. And this particular graph, if you look at the two middle lines, the purple line and the light orange line, that's a reflection of what I just described nationally. That's heroin, and that's fentanyl. Killing Vermonters.
This is shocking and dismal.
It's shocking. It's dismal. It has us back on our heels. But I tell you, as a Vermonter, we have so much to be proud of in this state. Governor Shumlin in 2014 declared that the #1 threat to quality of life in Vermont was heroin. We have the Office of Alcohol and Drug Abuse Programs. We have compassionate law enforcement. We have thousands of people in Alcoholics Anonymous and Narcotics Anonymous every day trying to reach out to these populations. We have education. We have prevention programs. Vermont is the only state, really, that satisfies there's 6 different policy areas that will increase people using a Narcan, which is the antidote to overdose. Vermont is the only state that fulfills all 6 policy areas. The National Service Council has 5 criteria in which they evaluate states and their performance relative to the opioid epidemic. Vermont meets 4 of the 5 criteria. We're one of 3 states in America that meets 4 of the 5 criteria. You have Mayor Weinberger, you have Chief Del Pozo out there having public forums all over the place. I mean, Vermont, we need to be it's a dismal situation. We are back on our heels, but we should be proud as Vermonters because we are stepping up. We are a model to every other state in America because of the way we're handling this.
This is good news, Ed, but at the same time, people are asking, why can't parents, why can't teachers, why can't the law enforcement control their children and just tell them to stop taking these drugs?
All right.
And why is it that the policy of just say no has not worked?
All right, we'll get to that right now. We'll get to that right now. What you're describing really, Margaret, is brain disease. You know, people who expect others with addiction to say no make the mistake of thinking that addiction is a matter of willpower, a matter of choice, a matter of deciding to say no. Or they think it's a moral weakness. If you could just try harder, you know, you'll stop doing that. We know today that this is not the case, that addiction is a brain disease. Research over the past 40, 50 years into addiction and the brain has really taught us a lot about the human brain. There are mechanisms in the brain that are impaired, that are hijacked by the self-administration of psychoactive chemicals. Motivation, learning, the ability to inhibit impulses, judgment. These areas are specifically impaired by the self-administration of drugs and cause addiction to perpetuate itself against the person with addiction's will. This is the tragedy of it. People will go on engaging in addictive behavior and every fiber in their body screams, stop, stop, this is unhealthy.
So the person is not in control.
The person is not in control, and this is one of the problems with the way that people understand this. There is no choice in the development of addiction. There are predisposing factors. There are very, very powerful genetic factors. There are very, very powerful environmental factors. No one chooses the life of addiction. I've known many people with addiction in my life, in my office, at AA and NA meetings, myself included, personal friends that I'm very, very close with. Not one chooses to become addicted to one drug or another. It's a matter of being predisposed. When you add the genetic predisposition and environmental predisposition to access to a psychoactive chemical, then you have the beginning of addiction. Certain people will begin to seek out those chemicals more forcefully, more strongly than others, because they're predisposed because of internal conditions. Take, for instance, a child. A child does not choose which family to be born into. How about a child with a mother or a father or both that have history of addiction? That child is predisposed genetically toward developing addiction. How about a child that's born into a family that exhibits what we call ACE, adverse childhood experiences? So neglect, abuse, chaos, violence. A child is born into a predicament that is not conducive to the development of health. That child is very likely to develop an inner world that's colored by suffering, that's colored by anxiety or depression. When that child grows into adolescence and is exposed to a psychoactive chemical that soothes that inner suffering, that child will seek out that solution to inner suffering. That person is not choosing to seek addiction. They're choosing to relieve inner suffering. Well, what's happening under the surface in the brain is causing addiction. I tried to think of a metaphor, and I think you'll understand. Do you remember Bernie Madoff?
Of course, yes.
Bernie Madoff, maybe your viewers are familiar with him.
Yeah.
Bernie Madoff was a con artist who had a Ponzi scheme, and he got a lot of people ready for retirement age to invest their life savings in his investments. And he told them, this is going to grow faster than the stock market. This is a sure thing. You know, this is going to be great for you. They invested their money, and what happened? Their lives were destroyed. Everything was taken from them. That's an analogy with addiction. Saying people choose a life of addiction is like saying people chose to invest with Bernie Madoff knowing that they would lose everything.
That's a very strong analogy. And you're talking about a tragedy that is very hidden. It's like a secret inside each one of us. So people with addiction. It's very interesting you bring that up, because you know the way we develop naturally psychologically, we have like unconscious processes that protect us from experiencing uncomfortable emotions. They're called defenses. So we naturally will defend ourselves against thoughts or ideas, or sometimes the truth about ourselves, if it's uncomfortable. People with addiction will employ unconscious defenses. It's not that bad. I only do it on the weekend. Everybody does it. I did it for that. I did it for this. They'll defend themselves against seeing that they're progressing in a disease pattern, while under the surface, the disease is taking hold and it's deepening. By the time a person realizes that they have a serious problem, they're probably suffering from brain addiction. And then it is very, very difficult to do something about that. In fact, you cannot do something about that on your own. You need help.
you need psychotherapy, and with this particular population that we're talking about today, we very often need medication-assisted treatment.
And Ed, I know we'll get into many other things, but what about the people who are, the parent of a child who becomes an addict? I mean, what support do they need? And what support is there for them?
Well, I am a psychotherapist by profession. I've practiced for over 30 years. So I believe in psychotherapy. And I think that, well, first of all, parents need to be educated about this. Yeah. We need to be funding programs that educate parents about this so we can the next generation will not be as naive as this generation about this terrible problem. Second of all, if you already have something happening in your family, I would highly recommend reaching out to a counselor, a therapist, someone who has what's called an LADC, licensed alcohol or drug counselor, or certainly the social workers today and the licensed mental health counselors today are all pretty well versed in this particular area, but the people who specialize in this area are licensed alcohol or drug counselors. I have a resource list at the end of the presentation that has the Office of Alcohol and Drug Abuse Programs website, where you can also go for help and find different resources. My advice to parents today is to love your children as you would, but be on guard. Watch them like a hawk. Watch them like a hawk. And if you have some suspicion or some inkling, some whiff of something going on that's not right, look into it, talk to them, find out what it is. The worst thing that can happen is that an adolescent whose brain is not fully developed enters into a relationship with a psychoactive chemical, and that goes underground, submerges like a submarine, and you can't see it. If you don't see it and you don't deal with it and you don't talk about it with your kid, it's getting worse. So parents really need to watch their children like hawks. It's not distrust. It's being well informed about the reality that we all live within. It's not distrust at all. It's love.
And a lot of parents also have the predicament where they have a child with some kind of a problem, a behavioral problem, and a doctor will then prescribe drugs to alleviate that. And somehow that goes into the whole story that you're telling too, doesn't it?
Well, there's a difference. I think opioids specifically were overprescribed for pain. They were used as a routine treatment for chronic pain. And pharmaceutical companies did research that kind of proved that there was a very minimal risk for addiction. We know now that that's not true. Purdue Pharmaceutical had to pay between $600 and $7 million in fines. They pled guilty to intentionally misleading the public regarding the addiction potential of OxyContin. So the information that was out there was faulty. So I think doctors who thought that they could help their patients with pain and were being reassured, remember the pain is the fifth vital sign. Pain is no longer a vital sign. We made the mistake as a country that we could live pain-free. America consumed over 90% of, I think, oxycodone produced. 5% of the population consumed more than 90% of the opioid produced. So we got a little off balance there. As far as other medications, if you have a doctor or a psychiatrist and you have a child with a diagnosable emotional disorder or mood disorder or some type of diagnosis that needs medication, I'm not prepared to discourage people from following medical professionals' advice. I am prepared to tell patients, every patient, that if you're with your doctor, you want to question your doctor about the addiction potential of the medication he or she is giving you. And you want to know exactly, none of this take as needed. No, when do I take it? How long do I take it for? Do I need it to be that strong? when is it going to be over? Because there's a lot of addiction in our culture.
Yeah. Well, Ed, can you tell us what methods are working to treat opiate addiction?
I can, and that's a pivotal question. With regards to opioid use disorder, there's a couple of different medications that research, very, very focused research, is unequivocally showing works best to prevent death with this population. Those medications are called medication-assisted treatment. I'll speak about two of them today, basically methadone and buprenorphine or Suboxone. You've heard of these things.
Yes.
Methadone and buprenorphine. Basically, in order to understand why these medications are used and why they work, you have to understand what's happening in the brain of a person with opioid addiction. What's happening is the person with opioid addiction has learned, their brain has learned to function relatively normal with the presence of a certain amount of opioids. Okay, that's called dependence. If that threshold lowers, it's greatly diminished, or there's an absence of opioids suddenly, the brain will go into what's called withdrawal because it's accustomed to operating with the presence of opioids. Now, withdrawal from opioids is extremely uncomfortable. Sweating, shaking, chills, stomach cramps, muscle cramps for a week. Nobody is going to go through that for a week if they can go outside and buy some opioids. And that's a lot of when people will die from opioid overdose. So the two things that opioid-based medications will do, they'll reach a balance in the person's brain, it's the locus coeruleus. They'll reach a balance in the person's brain that prevents them from entering into withdrawal. Okay? But the other side of the scale is that the dose will be exactly determined so what's called opioid intoxication does not become a problem. So the person does not go into withdrawal, but they're also not intoxicated on opioids, so they can function. They're stabilized. They can engage in other therapies, psychotherapy, couples therapy, work training, nutrition, whatever the therapies are. They can live a life because they're not threatened by withdrawal. They don't have to go out and seek opioids on the street, but they're also in charge of their faculties. They're not intoxicated. That's what these particular medications are designed to do.
And how does the person feel on these?
The person will feel basically normal. There might be, sometimes there's a short period of time where they may feel a little bit of an opioid effect, maybe, but it's a very short period of time. If the dosing is arrived at correctly, at the proper dose, the person will not feel what we call high, and they will certainly not be in danger of withdrawal, so they can function.
Okay.
This is a program in Vermont. This is the medication-assisted treatment in Vermont. And if you look at the numbers are higher now, but in January of 2017, we practically had 6,000 people in treatment with this MAT in Vermont. So this is 6,000 people that would not be medically stable, that would be out there left to their own devices, and you can imagine what the death rate would be without this particular medication. Another reason for us to feel very proud as Vermonters is if you look at the waiting list in January was 145. I think it's around 133, 130 now. This is not good for the 145 people that are waiting.
Right, right.
But when you look at it in perspective, we are doing an excellent job of making this important treatment accessible to people whose very lives are at risk. Another thing that's important is Narcan or Naloxone. Naloxone is the antidote to overdose. So if you have a person with too many opioids occupying too many receptors in their brain, and they're beginning to stop breathing, if you administer Naloxone, or what's called Narcan, it will instantly boot the opioid molecules off the opioid receptors, and the person will be revived. So again, if you look at these numbers between 2014 and 2016, approximately 950 people were administered Naloxone. So you can imagine again, the death rate would be even higher.
This is really hopeful for that community. And who has this naloxone? Is it only the police departments? Or?
We have a demonstration project in Vermont where it's being made accessible to what's called partners, so recovery centers, mental health centers. It's being distributed to family members, people who would be likely to be around someone who may enter into an overdose state.
Yeah.
The ODAP website that I have in my bibliography,
Yeah.
people can find out more about it there. This is a pilot project. We should be very proud of this.
Good, good. And the needle exchange and all of that?
We have a needle exchange where people can, unfortunately, if they are injecting opioids, they can get needles, clean needles. The rate of HIV, the rate of hepatitis C is greatly diminished when we take actions like this.
Yeah. Oh, that's a tragic side. That's tragic that there are more cases of HIV because of dirty needles in the drug world.
It's one of the main ways that that particular disease is transmitted. That's why it's very, very important to help these people.
And Ed, what are the 4 or 5 success criteria that you mentioned earlier? Did you
That's
already?
the National Security Council.
Yeah.
Educating of physicians, prescription drug monitoring program, the distribution of naloxone, the accessibility to medication-assisted treatment, and the elimination of pill mills. It's interesting. It's kind of funny. The only requirement that we don't meet is the elimination of pill mills. Pill mill is where anybody can go for $100. They can get a diagnosis and get a huge prescription of opioid pain medication. They're practically eliminated. They were very popular in Florida for a while. So we haven't eliminated those. And I wondered, why haven't we eliminated those? Then I thought for a minute, and I thought Vermont. It's because of the beauty of Vermont. A place like that could never survive in Vermont. We didn't have to eliminate them. They never got established here. It's because of you and me, the way people relate in Vermont, the way we talk about things, the way we would never tolerate anything like that. So that's the only criteria we haven't met, but we didn't have to meet it. So we are, I'll say it again, we are examples for the rest of this country.
And Ed, we're going to wrap up this segment of our talk.
Okay.
Now I want you to come back for part 2 on this enormous subject, if you will.
I would be very happy to.
Yeah,
I would be honored.
Oh, thank you very much, Ed. But could you wrap us up now with what we can do? And viewers, I implore you and myself along with you, just if we make this tiny little wake up, if we just wake up just this little bit with this knowledge of what is going on and what can be done for so many people in pain, then we're making one big step.
Absolutely. Well, what we can do is we can encourage attitudes of inclusion.
Yeah.
We can encourage attitudes of compassion. We can encourage people to understand that this is a disease, that it's not a choice. Like any other legitimate medical disease, multiple sclerosis, diabetes, cancers, lung disease, addiction, it has to be up there with all the other legitimate diseases so it can get adequate help and people can get better. I'd like to tell the audience that one of the things we can do is begin to talk about this particular population in language that's compassionate. Using words like, oh, he's a drug abuser. The word abuser puts you in very bad company. You think of child abuse, you think of spousal abuse. The person is not a drug abuser. A person is a person with a substance use disorder, like a person with an eating disorder. We don't call them food abusers, okay? But that we can use words like, substance use disorder is one of those, or person with addiction. Person first language. This is very, very important. And speak of this particular population with compassion in our hearts. This comes from 2013, the National Office of Drug Control Policy had a summit. They decided to relinquish the war on drugs and adopt a public health approach to addiction, What they found was that language is an important key. The way we speak of addiction is important, because when we speak of people with addiction with disparaging tone or disparaging phrases, they become stigmatized, they become isolated, they're less likely to seek help. So what we have to do is speak a little bit differently and include them with compassion. Bring them into the community. You're not different. It could be me. I could be you. I could develop addiction. Let us help you. And in that way, people get adequate health care and they begin to heal, spread the message, and they carry the message to other people with addiction.
Okay.
So learn about it, read up on it, support legislature that funds programs in healthcare adequately, and I've included a bibliography that I think is important for people to take a look at it if they want to learn more, and also my contact information is there.
Thank you, Ed Baker. Thank you for waking us up.
Thank you, Margaret.
Yeah.
Thank you for having me.
Thank you, viewers. More later. Goodbye for now. Okay. Very good. Terrific, Ed.